time it is being done in our further postgraduate examinations. Now, doubt clearance regarding the theory paper. See, this is the most important topic of today. So there are actually, all of you know, there are 4 papers, of which paper 1 is basically consisting of the basic science of all and also the non-orthopedic problems, as also the orthopedic and also related basic sciences. And in most of the examination, this paper is extremely important, because in some examination there are some conditions that this a student should pass separately for this paper 1. And this paper 2 is basically the fracture and the trauma. Paper 3 is basically the diseases, and the paper 4 is basically the rehabilitation, orthosis, prosthesis, and also the recent advances. Now, paper 1 is mostly important. I already told why it is in some examination. It is student should pass separately on paper 1. That is one. Second, and it is the most neglected part of all corners of the orthopedic fraternity. So that is why we are actually, I am devoting this evening for considering the paper 1. So these are the examples of questions of the paper 1. So how to write? This is my motto. So basic format is extremely important. This is please see attentively. So this is the introduction. So we'll go by this common format. This common format should be followed in all questions. Next one is the pathogenesis or the pathology, or any descriptions like the anatomy, physiology, like this. And in most of this is the most boring part of the all examinations. So always try to make this by flow chart or the diagram. This part, this is most important. Introduction is basically why you are going, what is the importance of that. So introduction may constitute the anatomy or the physiology, or what is the definition and what is going to become done. That is the agenda. Everything will come in the introduction. Next one is the pathogenesis of the pathology or the physiology.
Lost the sound, no?
Yes, sir. It's
and the video.
We'll just call.
The slides are there, but we lost the part.
Okay, sir. Yeah, yeah, please. Okay.
We connected?
Yes, sir. He's trying, sir. So meanwhile, may we ask Avinash, what all question you have faced which you find difficult for Avinash? Avinash and Narayan, these two people have appeared for Avinash.
Yes, sir.
Yeah. कहाँ प्रॉब्लम हुआ था ये बताना.
Sir, actually, question वो उठा रहा हूँ सर, खोज रहा हूँ question papers. Sir, in paper 1, almost all questions were good, except is synovial fluid characteristics in pyogenic arthritis versus non-infective inflammatory arthritis. I think I was not specific in that question. Sir.
What about other papers?
Sir, in paper 2, Schurman's disease, I think I wrote it wrong.
Which one?
Schurman's disease, sir. Schurman's disease.
Schurman's, huh?
Okay.
And one more question I can remember, the hip Elizarov ring for hip joint. I was not sure because I never seen that.
Well, you've seen pelvic support osteotomies.
Yes, sir, pelvic support osteotomy I have seen.
Yeah. So that's the main, and you can use it for distraction. Those are the two basic concepts for the hip joint.
Yes.
So arthrodiatesis, like in Perthes, some people use it.
Sir, I wrote it anyway, but I was not sure whether full ring to draw or half ring to draw for hip.
So how will you get a full ring along across the hip?
Sir, we can't.
Jude's arches. Then you have a full ring lower down. But at the hip, it's difficult to have a full ring. Impossible.
Sir, I found two questions difficult in all the four papers, sir. One was Pali classification in the congenital pseudoarthrosis of tibia. I remembered word classification and I wrote that.
Okay.
And one question, sir, that motorized limb lengthening in recent advances. Apart from these two questions, sir, all the questions were very easy, and I was very confident that I will clear this exam, sir.
In all the papers?
Yes, sir, in all the papers, only two questions, sir, I found difficult.
Sir, for motorized limb,
musculoskeletal syndrome in HIV.
Yes, sir, that also I have written.
What did you write in that? Because
exactly, I don't remember, sir, what I wrote, but polymyositis and those.
Yeah, so those questions you have to. It's difficult to know exactly what they're expecting from you.
Yes, sir. I will apply for the answer xerox of the answer sheet. They will give, sir.
Okay.
Okay. Sorry for the interruption. Okay. Hello.
Yes, sir.
Yeah.
What we are talking about the introduction, so that will contain the anatomy, physiology, everything. definition. Next is the pathogenesis or the pathology should go in the flowchart diagram. Clinical diagnosis should contain the diagnosis and the differential diagnosis. So you should go same format. If you go to the same format, you can write anything. So that will actually that will make some sense for completion of this answer sheet. Next is the investigations. See, if you think of the investigation should always be would be classified into non-invasive, semi-invasive, or the invasive. Non-invasive is like the radiograph, CT scan, MRI, depending on that what we have, what is required. Semi-invasive, so always think in this manner. So if it like semi-invasive, like the FNAC or the core needle biopsy. So, or suppose we are going to write any tumor, so we can write it the specific investigation. Tissue diagnosis can be done either by the non-invasive, it may be required the X radiograph or the CT scan, everything, or the core biopsy, and the invasive with the biopsy. That is the incision biopsy. Next is the counseling for the treatment, prognosis, and the complications. Treatment is always treatment. Think of like this: it may be conservative, semi-conservative, or the operative. And lastly, the complications and the management. So if you follow this, you can write anything for any point. So there are you have to divide your answers into different categories. Now I'm going to that. Specific diseases like Kienböck's disease. Introduction to the Kienböck disease is the avascular necrosis of the lunate, which can lead to progressive wrist pain and abnormal carpal motion. So it is common in between the 20 to 40 years. The causes, trauma may be precipitating factor. See, there are several causes I'm not going to detail because of the short time. So so how can it be make it a flow chart? So this is a pathogenesis of the Kienböck disease. So this is my handwriting. So everybody can reproduce on this. So there are two factors. One is the mechanical factor and also the physiological, the biological factor. So the mechanical factor is the excessive load. That may be the negative ulnar variance, and there is the most important cause, whereas there are several vascular cause. So there is that reduces the vascular supply on the lunate. So it is the pathology, and the pathology will be reflected on the radiography. So the pathology is the avascular necrosis, that will be the in initial period there are radiological feature, but once there is some necrosis is already sets in, there is a in the radiography. Next is the collapse. It is continuous structural collapse. And
There's some background sound. Make sure everyone's muted.
It will be reflected by this as well as reduced size and the irregular shape. And next, if it is advanced, that will lead to degeneration of the radioscaphoid joint, and which is reflected by reduced radioscaphoid joint space, subarticular sclerosis, cyst formation, and the osteophyte, which is the full-blown picture of the degenerative arthritis. So clinical diagnosis, again, as already told, so we have to break it in different categories, like the symptoms is the dorsal wrist pain, usually activity related, more of in the dominant hand. Physical examination need to be on inspection, palpation, range of motion, imaging. Just I'm going to read and have just my aim of this presentation is how to write in different subcategories. So that is, everything is written in the book or anywhere in the internet. So just make it a subcategory like this. There is symptoms, physical examination, inspection, palpation, range of motion. Now come to the imaging. First is the radiograph. The CT may be required for extent of the necrosis, whereas trabecular destruction, the lunate geometry, whereas MRI is the best diagnosing for the early disease. And the findings is the decreased T1 signal intensity, reduced vascularity. Now the stages. So this is very difficult to remember the stages: stage 1, stage 2, stage 3B, and 3 and 4. And there's a Littman classification. So how to write is very small, very useful way. So this is my handwriting. So this is the stages and the treatment depending on the stages. So you see, this is the stage 1, where there is radiologically there is almost no abnormality. But if you do the MRI can easily diagnose this. So only you can diagnose the causes like the negative ulnar variance, as you can see, like you can draw this in this manner. And this is the lunate. And then the second stage, there is a sclerosis, and the stage 2, 3 is a collapse, the size is reduced. But the stage 4, it is a degenerative. So see, this is the joint space reduced, and there is some irregularity, and also there are some, if you draw, you can draw the subchondral sclerosis and also the cyst formation. This is a stage 4. Now treatment, again, this is non-operative and the operative. And so non-operative, so they have the observation, immobilization, insets, and some orthosis, we can write it down. And the outcomes, the majority of this patient will undergo further regeneration, require the operative outcome, operative treatment. See, there are several operative treatment. We have to write it down, the principles and the indication, like this. So temporary STT pinning, so joint leveling procedures, radial wedging osteotomy, vascularized bone graft for the stage 1 and 2, and most is stage 3 cases. Whereas in the distal radius core decompression, again, it is doubtful role. Again, it is early disease. Whereas in the late cases, is a proximal row carpectomy, wrist fusion, or the total wrist arthroplasty may be the treatment of choice. Now, impact of surgical procedure, it is not mandatory to write. If anybody try to write, if there's any, if you can get the time, they can write it down. And you can see this, the percentage of the decrease of radiolunate contract stress, it is a maximum, is a capital shortening the capitohamate fusion, but it is a minimum for the capitohamate, only capitohamate fusion. So this is most important point for circulation. Now the quadrilateral space, how to write the quadrilateral space? Now again, the introduction. So introduction, you have to write out the anatomy and the boundaries. See the boundaries, the teres minor. See the teres minor, teres major, it's a long head of triceps, and also the humerus. See, there are actually, this is the quadrangular space, and say there is a small triangular space. This is another triangular space. So this is the quadrangular space. So we have to write it down. What to mean by this? This is the space. This is bounded by this. And through this space, what are the contents? Most important is the axillary nerve and the posterior circumflex humeral artery. But what is the point? What are the other points to be written down? Most important is the quadrilateral space syndrome. This is most important. It is of clinical importance. So what is the diagnostic point? See the posterior shoulder pain, the weakness. So see there are the precipitating factor is the overhead activities. Overhead activities, especially repeated overhead activities, especially that. So who will do the external rotation as also the abduction, and the age of, basically the age is affected 20 to 40 years. And there are several causes. Most important causes is the fibrous bands, which is connecting between the long head of biceps as also the humerus. So the most important. So how it draw the picture? So this picture is very easily drawn. See, this is this is scapular border. This is the glenoid, and this is the humerus, as you can see here. So you can write, you can draw very easily. So this is the long head of biceps. You have to write it down in this. You have to make it the leveling. This is 1, 2. So see, the 1 is the teres minor. See, this is 2 is the humerus. 2 is the scapula. 3 is the humerus, like this. And see, these are the two contents. 6 and 7 is the axillary nerve and the posterior humeral circumflex artery. Now pathogenesis. How will it write down the flow chart? See, there are physiological cause and the pathological cause. Physiological cause is the repeated overhead activity, especially the abduction and external rotation. Whereas the pathological activities, already I have told, is a fibrous band connecting between the long head of biceps and with the humerus. So then also this SOL, that is space occupying lesion. It may be the muscles, it may be the bones, it may be the ligaments, or it may be the neoplasm. Muscles, the muscle hypertrophy, bones, maybe there's some dislocation. There's dislocation of the shoulder because the axillary nerve is passing just below the humeral head. Now ligament is a labral cyst, as also neoplasm. There any neoplasm which reduces the space, that can lead to the compression of the contents. So if the compression of the nerves, that lead to weakness, paresthesia, hyposthesia, whereas compression of the arteries is the gradual ischemia, and that is ischemic pain, which is maximally prominent on the posterior part, posterior shoulder pain, as also that may lead to weakness if it is continuous for a long time. See, there are several differential diagnoses. See, the differential diagnoses are like this thoracic outlet syndrome, everything, it will come in this category. And now how to investigate? This shoulder radiograph series, epilateral axillary, MRI may show the teres minor atrophy, and arteriogram may show the lesion in the posterior circumflex humeral artery. If you want to know the neural compression, you can do the electromyographic study, and that may show the axillary nerve involvement. And the diagnostic test is the plain lidocaine injection to see whether symptoms are abolished, that can be used from the posterior subacromial point. Now treatment option, again, is a conservative, And let's say if it is conservative treatment fails within 6 months, then the surgical decompression. Conservative maybe NSAIDs, avoidance the prescribing factor like this. Now the parameters of assessment. So this is how will you write it down the points by point. So all of you know this. This is a dash score or the quick dash score. You can write it down 1 or 2 sentences on this. This is also important for your answers. Shoulder pain disability index. This is SPADI. So this is the questions. Now again, this is the osteoid osteoma versus osteoblastoma. How will you write it down? Introduction. Basically, they are all bone forming tumors. They are tumors which laid down the bone. As also they are very much painful because these contain these tumors, core of the tumor contain the neural tissues. So basically these are the painful bone forming tumors. And what are those categories? These are the osteoid come under the categories of the osteoma, osteoid osteoma. Next is the osteoblastoma. It may be benign or aggressive. Again, it's a osteoblastoma like osteosarcoma, and it's a full-blown picture of the osteosarcoma. See, these parameters are overlapping: osteoid osteoma, osteoblastoma, and the osteosarcoma. So in between that, this is intermediate, this is a giant osteoid osteoma, and this is aggressive osteoblastoma. Basically, osteoid osteoma pathologically they are both the same. There is basically they are differences in their size. So how did I draw the picture? See, this is the remodeling unit. So any remodeling unit of the bone consisting of this, the osteoclast, which will come to the hematopoietic stem cells, as the osteoblast. They are coming from the mesenchymal stem cells. But both of these cells, they work together. And see, the osteoclast that cutting the cones and they vacuate the area, and this vacated area is filled up with the osteoid, which is that osteoid is oven bone, which is laid down by the osteoblast. So the osteoclast and the osteoblast is the remodeling unit, and that remodeling unit will be very much prominent in this all case of this osteoid osteoma and the osteoid blastoma. And see the osteoblast, this is the normal osteoblast, and once they lay down the bones and this oven bone, once they are become very much calcified, so they are devoid of the nutritions which are coming from the periphery. So if these osteoblasts, they are not getting the nutritions, the cells are being shrunken down, but they contain the processes. So these are basically the osteocyte. So once they become dormant, so their cells are they are buried in the midst of the oven bone and calcification. So this is basically the basic things. And so if you see the osteoid formation, so these are all osteoid forming tumor. So what is osteoid? That will come in your introduction. So this is osteoblast. They will let down the osteoid. Basically, these are the oven bone. Also basically the immature bone which contains the much more matrix, and the water content is much more than the lamellar bone. So this is the osteoid forming. But if the osteoids are basically they are surrounded by these cells, which are normal cells, the osteoblast. This is the normal or the reactive osteoid. But see, if these osteoids are not surrounded by any cells, on the contrast, on its periphery, their cells are basically the spindle-shaped cells with the multiple nuclei, or there's some nuclear pleomorphism. So, and the cellular atypia is that the cells are different shaped. So these are basically is a tumor osteoid. So if you see this category, so these are reactive osteoid will come. This sort of reactive osteoid will come in this most benign form, whereas in the tumor osteoid will come in the most malignant form, the osteosarcoma. This is the other spectrum of the disease. So these are the histology. I'm not going to drill, because if you write it down, that is the most important. The types of the osteoma. So basically, what is the basic osteoma? So osteoma is a lamellar bone with evidence of remodeling. That means the normal osteoblast and the osteoclast in the midst of the osteoid formation is the osteoma. But our point of interest is the osteoid osteoma. What is that? Osteoid osteoma. Basically, this is it is a benign, painful. This is a bone forming tumor. So basically, see, if you see, there is a nidus. So there's a there's a radiolucent area, and at the center of the radiolucent area there is a calcification. If you see in the magnified view, so there's a central, this is a CFR. If you have to remember CFR, C is for the central calcification, F is the intermediate fibrovascular stroma. This is the vascular. This is extremely vascular. So this is the vascular theory of it is becoming painful because as there is some prostaglandin forming, prostaglandin is produced in this area, and there's a vascular vasodilatation. There is a high hypertension is produced inside that area. So there is increased tension, vascular tension, that can cause pain at the night. Another theory is the neural tissues. Neural tissues are coming, which is around this bone form and around these blood vessels. They're also responsible for the compression of the cellular structures, and also the let down the reactive bone formation that may cause pain at the end of the day, so the night. And that as their prostaglandin forming process, so that can easily respond with the insects. These are the explanation. So these are the needles. So these are the histology of the needles. You can write it down or draw in this manner. I'll come. So what is a nidus, osteoid osteoma? As you can see here, osteoid is osteoid forming tumor, but at the banks of this osteoid river, you have to see the osteoblast, and some areas it says osteoclast. How do you identify the osteoblast and the osteoclast? Osteoblast is basically the circular ovoid cells, but the osteoclast is a large cells with some processes. See, these are the osteoclast, and the nucleus may be multiple nucleus. So this osteoblastoma, basically this is a large, the size is much more than the osteoid osteoma, but this basically the characteristic is same. These are the osteoid forming, this is the osteoid formation, and also at the bank of the osteoid river, there are some osteoblasts are already there, but there may be benign or that may be aggressive. So how do you know the aggressive? See, these are the aggressive osteoblastoma. These are basically the cells. Some cells are very much plumpy. They are very large cells, and there's a nucleus with a prominent nucleoli. And lastly, the last picture is basically it is a osteosarcoma, where the less like osteoids, on the bank of the osteoid, there is no cells at all. On the other side, there may be the cells of the different shape and size with multiple nuclear shape. So how to write it down? How to draw this? So this if you see the long bone, so you can see the sclerosis, maximum sclerosis. This is a reactive sclerosis. You cannot see the nidus. Nidus can only be seen with the help of the CT scan. It is a cross-sectional study of the CT scan, where you can easily identify the nidus. There's a central radiolucent area with a central calcification. And the histology you can draw in this manner. It is very easy. See the central calcification, the intermediate perivascular structures is the vascular structures, which is surrounded by the neural tissues and the reactive bone. So peripheral reactive bone, the CFR, you have to remember. And see the nidus, basically what is the inside that? Is osteoid with osteoblast and osteoclast. So these are the osteoclast. I already showed you can write it very simple manner. So osteoid osteoma is an intracortical lesion. The osteosarcoma is a large lesion, whereas osteoblastoma basically it is in between that. Osteosarcoma, see this is less like osteoid, but at the bank of the osteoid there is no cells. On the other side there is anaplastic cells with nuclear pleomorphism. So how to differentiate? Age is basically it is osteoblastoma. 80% age is below 30 years, whereas osteoblastoma, osteoma. It is 90% age is below 30 years. Incidence is relatively common, whereas it's osteoblastoma is relatively rare. Sex ratio, it is much more common in male, whereas it is relatively much more common in male. So this basically the osteoid osteoma is a smaller variant of the osteoblastoma, and basic difference is it is in the size as also the histology. So this is the basically. So how the treatment is basically, if it is symptomatic, then we have to remove it. And you see there is a 4% recurrence chance in the osteoid osteoma, but in osteoblastoma, even if it is benign, there is chance of recurrence is more than 10%. So osteoma, it may be treated by observation, symptom management with NSAIDs. There's a radio frequency ablation with scintillation probe, the microwave ablation, there's a magnetic resonance guided high frequency ultrasound, and intralesional resection. But as osteoblastoma, basically site of lesion is also important. Osteoid osteoma, basically it is the peripheral bone is affected, where the osteoblastoma it is very commonly seen in the spine. So marginal resection, curative bone grafting or the cement fixation may be required. Spinal fusion may be required if it is a significant spinal that's a back pain. It is most common cause of painful scoliosis. So osteoid, both the cases, osteoid osteoma and the osteoblastoma, the posterior part of the vertebra, that is the that is the pedicle is mostly important, mostly affected. And lastly, the radiation therapy with chemotherapy is surgically inaccessible. So again, see, this is a bone. This is the hypophosphatemic rickets. How to write it down? So basically, this you have to write it down, the basic pathology of the vitamin D metabolism, from the 7-dehydrocholesterol, vitamin D3 formation, 25 hydroxycholecalciferol, 125 by the kidneys, 1 alpha hydroxylase. Basically, these functions is increase calcium and phosphorus absorption, increase bone resorption. So it liberates calcium from the bone. But most important, we have to write it down. This is a phosphatonin. Phosphatonin basically is a fibroblast growth factor. All of the fibroblast, the fibroblast that contains this sort of growth factor, phosphatamine. Basically, this phosphatamine ultimate function is it reduces phosphorus, serum phosphorus level. So there are several causes. It is one of the causes of the rickets. What are the different other causes of the rickets that will come in the differential diagnosis? Vitamin D deficiency, calcium deficiency, renal loss, that is renal tubular acidosis. It is renal losses. There are several causes, but as our most important cause is hypophosphatemic ricket will come. But other causes that may come in the differential diagnosis, like the tumor-induced rickets, McCune-Albright, epidermal nevus syndrome, neurofibromatosis. Now, mostly they are inherited, like the X-linked hypophosphatemic rickets. It's X-linked dominant. The defective gene is the X chromosome, which is X-linked dominant. That is why the most of the risk, even in the carrier, the recessive variety, all the female of the family may be affected in this, as they are X-linked dominant, but the male may be affected. So all the siblings, as is X-linked dominant, most of the siblings may be affected. So how it be produced in the pathogenesis? So this is basically, it is the FEX gene. FEX gene, basically that product of the FEX gene that inactivates the phosphatonin, which reduces the serum. So this phosphatonin, how it acts? Now phosphatonin decreases the renal tubular reabsorption of phosphate, and so that there is an increased excretion of the phosphate. Increase of phosphorus, whereas decreases the activity of the 1 alpha hydroxylase. That is why it reduces the 125 dihydroxycholecalciferol. So it increases the phosphorus excretion as well as reduces the vitamin D formation. As a whole, there is a decrease of serum phosphorus level. But whereas this FEX gene that controls the phosphatonin, that inactivates the phosphatonin, so that maintain the phosphorus level. But if the FEX gene is defective, so this phosphatonin is very much active, increase level. So because as the calcium phosphate level is most important for the bone is required, as the decreased phosphate is there, that will causes the weakening of the bone. So metabolic profile is basically, this is a ricket. So how will you draw it? So this is the very simple structure, as you can see here. So this is the metabolic profile. We have to do the calcium, phosphorus,
Sir, I think he has lost his connection or what?
Yeah. So I'll just
Just call him and see what's happening.
Yes, sir. Sir, I think we have lost him again. So,
I said call him on the phone.
sir, ma'am.
If you can't get through, then we may call it a day then.
Yes. Please, sir. Sir is connecting.
Okay.
Yes.
Maybe we should ask him to summarize once he comes back.
Yes, sir. As soon as sir is connecting, then we'll ask him.
No progress?
सर अभी सर ने फोन नहीं उठाया था सर I think sir is trying to join but because of his network connection is not yet able to. Meanwhile sir, may I ask you the one thing what we have noticed is that whenever there is a question which is not very specific, like not subdivided into marks, like in these papers, the paper one, what we have seen, it is difficult to score in those questions, although that appears more simpler. But whatever sir has shown in the initial 2 to 3 slide, how to write those questions when it is asked as an essay to write, then it is difficult. So what is your view, sir, when like essay type of question has asked in the exam? So how to handle this?
I think what Dr. Pal mentioned in the first few in the first few questions where he showed the details, I think that's quite useful, because I think you have to have a certain plan in your mind and have this structure to your answer in terms of what all you are going to include in your answers, because time is really key when these long questions, which can be quite in the sense that there's quite a lot of information there and you need to try and condense it into what is important. And here's where I think practice becomes very important. Okay, so you practice writing the whole question and then summarizing the important points so that you can fit it into whatever. How much time do you get per question? So you have 10 questions and how much time?
Sir, it's 3 hours.
Okay, so 3 hours is 180 minutes, means 18. So 15 minutes a question at the max. Okay, so you need to plan how to write these down within 15 minutes comfortably. Okay, in a decent handwriting.
And so for like a few questions, when it is asked, there is not specified anything. So in those things, where to put figures or when not to put the diagrams, and when you're using the diagram, is it just a line diagram or?
No, I think it depends on what you're trying to say. So if you have a flow chart which is informative and relevant, it's useful. Similarly, diagrams are useful where they're conveying something, where you might use them not to have to write something down. Okay, so if you write everything down and then draw a diagram of the same thing, you end up spending too much time. Okay, so you have to kind of have some kind of correlation between what you're writing and your diagrams and your flow charts.
So we have seen one question.
It's not so when you're saying what question, have a question which you're thinking about, and then it may be easier to discuss that.
So in one, it was asked that difference between osteoid osteoma and osteoblastoma. So for those questions, how to proceed, and because there is nothing.
So I think he showed that, except that he also included osteosarcoma. But yes, so you write the initial description of what they are, or the definition of what they are. Then you show the clinical features and how they are different. Then the radiological pictures and how you differentiate them, the CT scan, MRI, whatever, and the treatment. Okay, so all those things come in one after the other.
Okay, so like when a candidate used to present a case in that way, like symptoms, signs, and in the clinical feature, then in the management investigation, in that one, what I have shown is non-invasive, semi-invasive, invasive, and then the treatment part. So for that semi-invasive, what actually it means?
So something like a needle biopsy. Okay, it's not major surgery, but it's still invasive. Okay.
Yes, sir. So I think.
Dr. Pal's back.
Yeah.
So we are already having discussions. So maybe you can just summarize, Dr. Pal.
Yes, just summarize.
Summarize, and then we can take the question.
Okay. So
So
just
going
to
through
summarize
each question, just come to the end and summarize the various points which are important.
Yeah.
Okay.
And
Okay.
because
So the Oliver's and Maffu's.
yes, sir.
Just
Actually,
I'm going through the slides. I'm just
Yeah,
going to the slides. Just to have a point to be noted. So Olliers and Maffu's syndrome, basically there is an introduction. So basically the chondromas, there are types of chondromas, and basically what is the difference? Maffu's syndrome is basically, what do you mean by the enchondromatosis? Enchondromatosis is the Olliers disease, and the Maffu's syndrome is basically enchondromatosis plus lymphangiomatous. So there are classification. How do remember the classification? Different classification. Just add one like this. Add just a simple enchondromatosis plus hemangioma plus exostosis plus for like this. Now the causes are basically this is the header. This is the genetic problems. That basically is the PTH, the 1 2. The clinical diagnosis, basically, this is the common characteristics of both the Olliers and the Maffu's are this, and the clinical presentation is like this. The basically different deformities of the limbs, and see the clinical pictures. Now, how to suspect the malignant transformation? This is the most important. So this is the clinical symptoms, and the basically the locations like the shoulder girdle, the staphyma, the proximal tibia, and features. These are the features, basically the radiological features, and also the clinical, the radiological features are most important to recognize for this malignant transformation. Now, radiological hallmarks, so it's basically the endosteal scalloping, cortical thinning, and the surrounding sclerotic rim. So this is the histology, and how to write it down. See, this is the enchondroma, and this is the chondrosarcoma. This ultimately, this is a multiple enchondroma, is enchondromatosis. Basically, if you draw like this, so this is the cartilage cells with this cartilage matrix, but the bones, these are the bones component, bony component that will remain. This is a remodeling unit. See, this is a remodeling unit. This is the osteoclast and osteoblast with osteoid formation. That would be always at the periphery of the lesion. Whereas in the chondrosarcoma, that bony trabecule is always surrounded by the chondrocytes. That is the most important. So it is in the periphery, this is in the center. So, and basically the basis of this popcorn calcification, as you can see in our radiograph. So these are the this is a clinical picture, this is a radiological picture. You can write it down in this manner. And the treatment, basically it is initially the conservative if there is no pain, but if it is operative if it is containing of pain and also the increasing size, intralesional curettage, and also there are several some specific treatment for their complications. Now the spasticity, rigidity, basically you can write it down in this manner. It's the introduction, basically the causes. These are higher upper motor neuron lesions. There are different causes of the upper motor neuron. You have to write it down. Clinical difference, these are the clinical difference, basically where lesions are basically in the pyramidal tract, and basically it's the basal ganglion lesion. Hyperthyroidism, there are different types, but there's a muscles, only one group, there's both the agonist and antagonist group are involved. And rigidity, the stretch sensitive, rigidity, it is a spasticity is a stretch sensitive, whereas rigidity is not stretch sensitive. So basically these are the differences. And there are the medical treatment. The focal treatment is a botulinum toxin, phenol alcohol neurolysis, botulinum toxins. It is a multifocal. Then along with that, we have to use the oral medications like the baclofen. And the regional therapies is the intralesional therapy, botulinum toxin injection, and maybe concurrently for different muscles in various regions you can used. And for the generalized intralesional intrathecal therapy along with the oral medication, you have to use. But if there's a general presentation, botulinum toxin or the phenol alcohol neurolysis can be considered. So how do you write it down the diagram of the treatment? Treatment is basically you have to start with the physical management, intrathecal baclofen, botulinum toxin, surgical options, and the oral medications. Again, and another is it may be focal or it may be global spasticity. So it may be it is a reversible therapy or it is a permanent therapy in this. So botulinum toxin basically is a reversible therapy, whereas the selective peripheral neurectomy, dorsal rhizotomy is a permanent therapy. So basically this is the these are the the technique. So my conclusion is, so always try to make a rhythm, where to follow the rhythm. So always try to the introduction. Next is the pathogenesis or the pathology, and if you require the classification on the stages may be required in this stage. And most of the cases we have to follow the diagram, or it may be a flow chart. Flow chart or diagram may be extremely important. And nextly, the clinical diagnosis. So always go by this flow chart: this inspection, palpation, movement, measurement. If you follow this, so you can write anything, at least 1 or 2 sentences that will enrich your writing. And lastly, the differential diagnosis, and the next is the management. Management will start with the investigations. This is a non-invasive and the invasive, and lastly the counseling and the actual treatment, and lastly the complications. So if you follow this manner, you can write everything, even without knowing the completely on any topic. You can write it down. I think this is my specific advice for the students.
Thank you very much, Dr. Pal. That was excellent. I think there's a lot of information conveyed there. We'll take some questions before we close for today. So any questions from the DNP students? Because I think this is really important for you people.
Sir, the questions are very specific, like they ask stages of the Perthes disease and its treatment. So sir, should we write all those introduction, pathophysiology, everything, sir, in that case?
No, definitely not. So if it is the stages and the treatment is required, that's very specific questions. So in that case, we have to do by very to the point answer. So stages, so we have to write it. We have to choose the which stages is required, and for the which is required, which is relevant with your treatment strategy. So if you start with the cateral, so cateral is basically there's some limitations for management. So you can write it down the cateral stages, but that is the principle of treatment. So but the most important classification which is directly related with the management is the Elizabethtown classification, or the Matthew-Varghese classification, which is basically the stage 1, stage 2, stage 3, and stage 4. Stage 1 is basically the sclerosis. Stage 1 is stage 2 it is the fragmentation. Stage 3 is the repair, and the fourth is it is a remodeling. So basically the containment treatment is basically, it is most important up to the early fragmentation stage. So if we enter into the repair stage, so no containment treatment is important. So you can choose one or two classification. Suppose the lateral heading classification. Heading classification is related with the prognosis. It doesn't dictate with your treatment, either plan of treatment or the specific treatment. So you should not write it down, but you have to choose either cateral or the Elizabethtown or the Matthew-Varghese classification. In this manner,
Matthew-Varghese or Benjamin Joseph?
Sorry, Benjamin Joseph. Yes, it is a Benjamin. Sorry, it's a Benjamin Joseph.
Maybe you can stop sharing your screen then.
Yes, I'm stopping. See, basically the questions are 2 or 3 types of questions. One is very specific, as you have already told, and then another type of is specific, like the classification of specific disease. So it's very extremely specific. So you have to write on this only classification. But if there is some recent advances, what are the you have to choose the different classification, their advantage and disadvantage, their limitations, their importance of different classification, like this. But if you write it down, what are the classification and the management. So in that case, we have to choose the classification which dictate the plan of management, and the classification which dictate the specific different types of management. So that is the important. So we have to choose the exact point to be written.
So may I ask, when it is asked the specific questions, like subdivision of question, then or when it is an essay type question, in which one candidate can score more marks and why so?
So in every question, the students can score high marks if they subdivide in different categories. So I always advise leave the left side of your answer sheet vacant. In left side, you only write the salient point, and on the right side, on the right half, divide the sheet into two half, on the left half and the right half. In the left half, only write it down the important topics, only the headings, only they write in the headings or the important the point which you want to highlight. On the right side, you can write one a sentence, 2 or 3 sentences like this. In between that, you have to write it down the flow chart or the diagram or any treatment principles like that, principal statement or the some pie chart like that. Okay, so but in every questions, so you can write it down much more, you can score higher up. The one question for short questions, if they are asking for classification, but there are, just please read down the question. Please read down.
I think that was the Paley's classification, was it?
Yeah. So first one asked by Subhansu, he want to know which book should choose for basic sciences and recent advances in ortho.
So there are several. So suppose the biomechanics. There for biomechanics and the metals, there are several recent advances already given, and the books of the Anand Thakur is very good. You can read it. It is I think it is one of the best book, I think, in Indian scenario. And other than the AO principle, there are several AO group books are there. So for the recent advances, for the minimal invasive technique, for the 3D printing, for the basically these are the consisting of the recent advances. And I think these are the AO books are very good for this, I think. Next one is the basic science. Basic science is basically it is related with the, suppose of the pathology. In pathology, there are some Walter Israel. I think it is very good. But if you see the Mercer and also the Turek, I think the Mercer and Turek's book is, I think it's very good. But you have to make a gist of that. Mercer and Turek's book, it is written in every elaborately. You have to make gist of that, as I have done. So I have shown this. You have just make it gist. And also you trained yourself to draw the picture. So, how
I think
draw the osteoblast, how to draw the osteoclast, the remodeling unit, so everything.
So I think the problem is everyone's not as good an artist as you, Dr. Pal. So it's
it is very easy, sir. It is very easy. If you practice it. So
yeah, that's the thing. That's the important thing.
It also helps you to identify the specific histological picture.
I agree. The practice is, I have not just of the diagrams, but how to write the questions down is important. I think unless you practice it, you will always be short of time and you will not know how to format your answers properly.
Always subcategories. I'll make it always subcategory. This is my advice. So think of in how will you break it? How you break the questions in different aspects. That is the most important. And make it it is I have already told, it's a 2 half of the paper, the left side the points, right side the sentences.
One question asked by Anjikya is that for short questions, if they're asking for classification, but there are many classifications in same pathology, so is it enough to write any single classification or how to choose among those classifications?
I discussed what I discussed. Suppose there is a Perthes disease. Perthes, there are several classifications, but so we have to choose it if it is required only the management, then the Catterall and this Benjamin Joseph classification is most important. If you regard for prognostic value, this lateral pillar classification. Okay, that in this manner you have to write it down. So suppose there is a classification of proximal tibia fracture. So proximal is a Suchkar classification, but in Suchkar classification there are several limitations. So at least you have to choose the most popular classification which is commonly followed, and what is the limitation, and if there is any other recent classification is already it is coming but it is not in the textbook, but you can write it down. Suppose there is a column classification of proximal tibia fracture. So there are 3-column classification, 4-column classification. What is the limitations of the such classification? What is the advantage of this column classification, 3-column, 4-column classification? That should, you have to write it down.
Yeah, I think that's good. So if there are no other questions, I think we should close it. We're already past 8 o'clock. Unfortunately, we lost some time due to technical problems. But if there are any burning questions, so there's one, how should you approach a completely new question?
Yes, suppose Kienböck's disease. I don't know what is actually the Kienböck's disease, but I know there are some. Just I know the avascular necrosis of lunate is known as the Kienböck's disease, isn't it? But other features, I don't know the treatment, if anything. So how will you start it? So I didn't read it, but problem is how to start it. So this is the avascular necrosis of this lunate bone. So what are the causes you have to think of? So what are the symptoms, or they have to pathogenesis? If you know this is a negative ulnar variance, may cause this, you can write it down. This negative ulnar variance may cause this because of the pressure. And if you know the avascular necrosis stages of the femoral head, almost similar stages is followed in this case. Ficart stage of avascular necrosis of femoral head. This the Littman classification is almost similar to that. So you have to write it down, the Littman classification. If you follow that avascular necrosis of the femoral head, same thing. Now the avascularity. So again, what are the treatment of avascular necrosis of the femur? So the same thing is a revascularization. Some in initial phase there is some joint preserving surgery. So in this case, same thing is it is followed. But as it is a expandable bone, so that can be done. You can write it down. It's a proximal carpectomy, or if it is significant. Suppose what you do in the avascular necrosis of femoral head, if it is in young patient, so in that case we do the orthodesis. If it is an older patient, avascular necrosis of femoral head, we do the arthroplasty. Same principle is followed. So if you know the basic principles of management of avascular necrosis of any bone, you can write it down. And always again you have to make it in separate it. So that is divide in different numbers. It is most important, as I've already advised. So in this manner you can write.
But I think that's important. You try to do that and categorize them, but sometimes you have to be a little careful if it's something that you don't know anything about. And I'm not sure whether you should just leave it or write something which is totally wrong. So I'm not sure what the correct answer for that is.
Yes, if you don't know anything, so that would be different. But avascular necrosis management is almost,
as long as you know that this is, you can always build up around it. Like he said, there are lots of, and I think that is again related to your observations in your clinical studies and practice.
absolutely.
Because pay attention to patients that come through the OPD and the wards, you'll probably cover almost everything in some form or the other.
Absolutely.
Okay.
Absolutely.
So I think we have covered most of the questions, sir. So thank you very much, sir.
Thank you very much, Dr. Pal, and hopefully we'll catch you again sometime. Bye.
Thank you so much, sir.
Thank you. We'll meet again. Sorry for the technical problem.
No, that's okay.
Great.
Bye.
Thank you, sir. We'll plan the part 2 for these papers, sir, because two more papers is here. So
Definitely.
Accordingly.
Definitely will do that.
Yeah.
Thank you.
Thank you so much.
Meet again. Bye.
Thank you, sir. Thank you, sir.